Welcome to the Hematology Clinical Scenarios, Part 3. In this module, we'll be dealing with some questions pertaining to the erythropoiesis and different types of anemias. 27-year-old was surprised to see her laboratory results, which showed a below normal hemoglobin concentration, about 8.4 grams per deciliter. She is otherwise healthy and no past medical problems were there. She takes no medications. Her MCV is 70 femtoliters, hematocrit 24%, red cell count 3.4 million per cubic millimeter, reticulocyte count 0.6%, WBC platelets were normal. Peripheral smear reveals anisocytosis and poikilocytosis. The question is, which of the following hematological values suggests that the condition of the woman is not macrocytic anemia? Now she has evidence of anemia as suggested by the below normal hemoglobin. MCV is slightly low, reduced. Hematocrit is reduced, red cell count is reduced, reticulocyte count is normal. Now you have to answer the question based on the investigations. Option A, hemoglobin reticulocyte count, hematocrit and red cell count. Reticulocyte count only, mean corpuscular volume. Now you have to indicate or come to a conclusion that her anemia is not macrocytic. The most important suggestion to macrocytic anemia is the blood indices. Basic investigation. Hemoglobin, hematocrit, red cell count, they are reduced in all types of anemia. Reticulocyte count is not a very good indicator of diagnosis of macrocytic anemia, but good indicator of hemolytic anemia. Now we are left with the MCV. If it is a macrocytic anemia, MCV should be above normal. Here MCV is below normal, so that suggests that the anemia is not macrocytic. So the hematological value that suggests that the woman is not macrocytic is MCV. If it were to be macrocytic, it's definitely more than this value, more than 80, 87. It should be more than 90. Here it is less. So that is the answer. This is the case 1. Case 2. A 36-year-old working woman has complaints of early fatigue, sleepiness during her work. She reports loss of weight in the last 6 months with premature graying of the hair. She has recently developed numbness and tingling of her extremities. Hematological investigation reveals anemia with high MCV and low reticulocyte count. Gastric analysis shows achlorhydria after histamine stimulation. This history is very suggestive of a type of anemia. The most likely diagnosis of the above condition, above anemia, is anemia of chronic blood loss, A, aplastic anemia, iron deficiency anemia, and pernicious anemia. Of course, the answer is D, pernicious anemia, because there is definite indication of pernicious anemia, which is due to the low intrinsic factor or deficiency of the intrinsic factor from the stomach. There is achlorhydria after histamine stimulation, gastric atrophy will be there, decreased parietal cell mass, decreased intrinsic factor secretion, decreased vitamin B12 absorption from the gut, resulting in B12 deficiency anemia, macrocytic or megaloblastic anemia. It is characterized by high MCV and sometimes low reticulocyte count. Is not very suggestive. And also suggestion of numbness, tingling between B12, neurological symptoms of vitamin B12 deficiency, also premature graying of hair sometimes there is in B12 deficiency. Of course, all others are common symptoms of anemia, sleepiness, fatigue, etc. So pernicious anemia is the answer. Case 3. An elderly male patient is admitted for the treatment of anemia. There is no history of acute or chronic blood loss. He consumes milk and protein-rich food regularly. He has significant pallor, beefy red tongue. His renal functions are normal. Has evidence of atrophic gastritis and reduced parietal cell mass. He is diagnosed with pernicious anemia. Which of the following changes in the kinetics of erythropoiesis would be associated with untreated pernicious anemia? So, untreated pernicious anemia will have characteristic changes in the bone marrow. Erythropoiesis will be ineffective. What are these changes? Let's have a look into the options. A. Decreased rate at which radio iron is incorporated into hemoglobin in erythroid precursor bone marrow. This is unlikely because it is pernicious B12 deficiency. Radio iron incorporation is not affected. It will be only affected in iron deficiency anemia. Hypoplastic bone marrow with increased myeloid erythroid ratio. It will be hyperplastic. It will be decreased myeloid erythroid ratio. It's not also not normal. Decreased rate of release of erythrocytes into the circulation due to intramedullary destruction. This seems to be the most likely answer because this is the problem in megaloblastic anemia. Accelerated DNA synthesis and mitotic division in erythroid precursors not correct because there will be a decreased DNA synthesis and reduced mitotic division. So C is the answer. The rate at which the erythrocytes are liberated, mature red cells are liberated in circulation will be reduced. There will be increased large number of large sized RBCs which are less lifespan will be liberated. And this is mainly due to decreased mitosis as well as the intramedullary destruction. It's called ineffective erythropoiesis. Now, case 4. A 60-year-old man is admitted for the following complaints: gradual onset of fatigue, sore tongue, weight loss, irritability, tingling in feet, and recent onset of difficulty in balance while walking. He denies alcohol consumption. On examination, patient is slightly overweight and has conjunctival pallor and mild icterus. BP 150/88, there's loss of vibratory sensibility in both the distal extremities, loss of joint position sensation into bilateral. This is a B12 deficiency anemia with neurological manifestations and symptoms and signs. Loss of vibration, loss of proprioception, tingling, difficulty in balance are all characteristic of vitamin B12 deficiency. Sore tongue along with that. Now there are some 3 questions. These 3 questions we will see. First of these 3. The bone marrow of this patient is more likely to show which of the following abnormalities. This is almost like the previous question. Defective incorporation of hemoglobin into erythroid precursors, not resistant iron deficiency. Defective DNA synthesis, maturation failure in rapidly dividing stem cells. This is the typical feature erythropoiesis change in macrocytic anemia. Defective DNA synthesis, maturation failure. B12 is known as the maturation factor along with folic acid. Marked erythroid myeloid aplasia. There will be hyperplasia. C is not the answer. Absence of erythropoietin sensitive stem cells. Erythropoietin is normal. So erythropoietin sensitive stems will be also normal. So B will be the answer again. So the second part of this question. So there will be some more investigations to this case. The lab investigations in the same patient reveal hemoglobin 7.6, hematocrit 24, red cell 2 million, peripheral blood smear showed marked anisocytosis. Anisocytosis is change in varying sizes of cells, RBCs. Poikilocytosis is varying shapes, red cells. Macrocytosis, large number of RBCs, large sized RBCs. Hypersegmented neutrophils. marginal leukopenia. They're all characteristic of vitamin B12 deficiency. Bone marrow examination show hypercellularity with megaloblast. Myeloid erythroid ratio normally is 3:1. Yes, 1:1. Erythroid hyperplasia is there. Abnormal large red cell precursors, that is large early normoblast or large intermediate normoblast, large late normoblast, and these are the red cell precursors which are in the bone marrow. They have, some of them have nuclei that appear to be less mature, less condensed, less mature when compared to the cytoplasmic maturity. So there is a lagging of nuclear maturity due to the DNA deficiency, characteristic vitamin B12 deficiency. With more dispersed nuclear chromatin, nucleus fails to condense and that stains less intensely than normal. This is characteristic of bone marrow picture in macrocytic or megaloblastic anemia. The second part of the three-part question is, which of the following statements regarding the myeloid erythroid ratio is true? So the question is on myeloid erythroid ratio of the bone marrow. It says ratio is normal since both red cell white cell precursors are equally diminished in marrow. This is not it is not normal. It's normally 3:1. More myeloid cells than erythroid, even though blood in circulation erythrocytes are many more than leukocytes. In the bone marrow, myeloid precursors are much more than erythroid precursors. Here it is 1:1, not 3:1. So it is not correct. Ratio is abnormal, right? Because of greater intramedullary destruction of red cell precursors. Let us see. It's not convincing. Ratio is decreased due to higher rate of ineffective erythropoiesis. Seems to be the correct answer. There is a higher rate of erythropoiesis, but ineffective. There's hyperplasia. The ratio is normal since the maturation failure does not affect the myeloid precursor. No, ratio is not normal. So C is the most convincing answer. Ratio is decreased due to higher rate of ineffective erythropoiesis. B is partially correct, abnormal because of greater intramedullary destruction. That's not the actual answer. Just some more investigation following this case. Additional lab values. Serum folate, normal. Serum vitamin B12, reduced, 97 instead of this value. Ferritin, normal. Serum iron, normal. Schilling test, which is for vitamin B12 absorption, revealed normal B12 absorption with the addition of intrinsic factor. You add an intrinsic factor, the B12 absorption becomes normal. That's the basis of Schilling test. Diagnosis of pernicious anemia is made. Patient started on daily intramuscular injections of cyanocobalamin for 1 week, then weekly injections for 1 month, and monthly injection for the remainder of the life. So there's a lifelong requirement of parenteral vitamin B12 cyanocobalamin for this individual because the intrinsic factor is deficient and B12 absorption cannot occur. There is a need for parenteral B12. At the 10th day after treatment, patient's reticulocyte count is very much increased, 30%. You know that reticulocyte count is an indicator of effective erythropoiesis. That means the person is responding. At 8 weeks, patient has marked improvement in neurological assessment. Look at this. The person has really responded to B12 treatment. Could walk with ease using walking stick. He used to have loss of balance. Now he can still walk nicely, at least with a walking stick. Hemoglobin has increased to 14 in such a low value. Reticulocyte 1.5% is reduced. So there is a peak and then reduce. Serum iron has slightly reduced and MCV has come back to normal. So I had to answer question 3. It has two parts, A and B. Normal A, 3A, normal vitamin B12 absorption with the addition of intrinsic factors suggests which are the following in this patient. I have first added, which absorption was normal. What does it convey? This is normal vitamin B12 absorption. There is normal vitamin B12 absorption in the patient, even in the absence of intrinsic factor. That's unlikely answer. Not correct. Intrinsic factors normally secreted, but vitamin B12 absorption is defective due to reduced absorptive area. No, here intrinsic factor is not secreted. So this is also not correct. There is secretion of intrinsic factor in sites other than the gastric parietal cells, and vitamin B12 absorption not affected much. No, this is also not correct. There is no indication that intrinsic factor secreted is not secreted anywhere else. D. Both intrinsic factor secretion, allele absorption are defective. They were defective. So when the intrinsic factor was added, absorption has reduced, has become normal. So originally both were affected, intrinsic factor secretion as well as due to B12 absorption because of this. So this is the correct answer. 3B. The reticulocyte response seen on the 10th day of treatment. This is called reticulocyte response. Sudden increase. It's called physiological reticulocyte response. Can be attributed to which of the following? Feedback inhibition of erythropoietin secretion. No, erythropoietin has no role here. Increased rate of effective erythropoiesis in bone marrow. This seems to be a correct answer. B. Continuation of the ineffective erythropoiesis in spite of treatment. No, the person has improved. Reticulocyte response indicates improvement or response to the treatment. So C also is wrong. Extramedullary hematopoiesis following treatment. No, that's also not correct. The person has responded and effective erythropoiesis has resumed. So B is the answer. Case 5. So we finished the case 4. 3 questions. The next case. A 60-year-old woman has laboratory evidence of macrocytic anemia. The peripheral blood smear also shows 6 lobe neutrophils. Which of the following conditions is associated with a lifelong requirement of parenteral administration of vitamin that's deficient in this patient? Now there are 5 choices, 5 options here. Deficiency, we have to, all are not correct. So you have to select a group. Deficiency of intrinsic factor, chronic kidney disease, removal of ileum, removal of jejunum, removal of stomach. You have to select more than one choices for the lifelong requirement of parenteral administration. There is a choice actually coming up, single best response. Let us now, without looking into the choices, let's see whether we can make an answer. Narrow down. Deficiency of intrinsic factor, yes, it requires lifelong treatment. Chronic kidney disease, no. Removal of ileum, yes, because you can't replace ileum. It requires. Ileum is the place where B12 is absorbed. Jejunum has no place for absorption, so it's not correct. So 1, 3, removal of stomach, yes. When you remove the stomach, you can't replace the stomach. You can only replace intrinsic factor or parenteral vitamin B12. So 1, 3, and 5. Let us say 1, 3, and 5 are there in the responses. 2 and 4 wrong. 1 and 5 partially correct. 1, 3, and 5 correct. 1, 2, 4, 5 not correct. 2 and 4 are not. So it's C. C is the answer. 1, 3, and 5.